We introduce the first speaker, Dr. Udari Kurasinghe. She is a senior registrar in hematology and rehabilitation attached to Rehabilitation Hospital, Ragama. And the expert opinion and discussion will be done by Govinda Abesigma, consultant in hematology and rehabilitation at Hematology and Rehabilitation Hospital, Ragama.
Good morning to everybody. First of all, I wish to thank the College of Specialty in Rheumatology and Rehabilitation for collaborating with the Sri Lanka Association of Clinical Pharmacology and Therapeutics in coordinating this particular CME activity for the benefit of particularly trainees in rheumatology as well as trainees in general medicine. Sri Lanka Association of Clinical Pharmacology and Therapeutics is a relatively new association. We formed it in 2015, and this year we thought we will have collective CME activities with other specialty colleges, because pharmacology is a field which cuts across almost all specialties, particularly specialties in medicine. So therefore, and we have our pharmacology academic staff with us, as well as now we have board certification leading to board certification in clinical pharmacology and therapeutics, PGIM. So therefore, there are pharmacologists working in all these specialties. So in order to show the relevance of clinical pharmacology to all specialties, we decided this year we will have these collaborative CME activities. And this is the second activity that we are having with other sister colleges. We had about 2 months ago, we had one with the College of Dermatology. So we are very happy. Specialties in rheumatology and rehabilitation for collaborating that. And it takes gives me great pleasure in introducing the last two speakers, because we are having an issue about, I think, for online participants, what we are saying is not audible. So therefore, we thought we will introduce the four speakers, and then they will come one after the other in the order in the program. So, and I thank Dr. Kumendika Kasturila particularly for President of your college for organizing this, and identifying the speakers. She introduced the first two speakers, and it is my pleasure to introduce Dr. Chiranti Yenage. She is now a board certified specialist in rheumatology and rehabilitation, and she is also a senior lecturer in the Department of Pharmacology, Faculty of Medicine, University of Colombo. And she will speak to you on therapeutics in polymyositis, when, what, and why. And it will be followed by the next speaker, who is also a pharmacologist, Dr. Sujivani Surya. She is also a senior lecturer in pharmacology at the Faculty of Medicine, University of California, and also and she will speak to you on prescribing special situations in rheumatology. So without further ado, I think we will get on with the program. And
can I invite Dr. Udari Kurasinghe to start your message?
Good morning, everyone. First of all, I'm grateful for the College of Rheumatologists for giving me this valuable opportunity. I'm going to talk about a therapeutically challenging case of polymyositis today. Let me begin with my case history. Sorry for the disturbance. Let me begin with my case history. My patient is Miss M, a 23 years old unmarried lady from Jharkhand. She first presented to us in 2018 when she was an 18-year-old A-level student. She presented to us with difficulty in walking, climbing steps, and getting up from the sitting position for 8 months duration. There was no dysphagia or breathing difficulty. There were no joint pains, oral ulcers, rashes, alopecia, or Raynaud's phenomenon, and there were no any other connective tissue disease features as well. And there were no other extraarticular manifestations, and no features of hypo or hyperthyroidism, no fever or constitutional symptoms. So on examination, her bilateral upper limb proximal muscle power was grade 4 and bilateral lower limb proximal muscle power was grade 3. All the reflexes were normal, plantars were downgoing, and the sensorium was normal. She had severe muscle tenderness, mainly of the proximal muscles. However, there were no rashes, oral ulcers, joint tenderness, or features of synovitis, and there wasn't a goiter, and the system examination was essentially normal, including cardiovascular system, respiratory system, and the abdomen. With investigations, her inflammatory markers were normal, ESR was 10 and CRP was 5. There was mild leukocytosis with WBC count of 10,400. However, hemoglobin and platelet counts were within the normal range. As expectedly, her CPK was very high at the initial presentation and it was 10,371. Her TSH was normal and her liver enzymes were elevated with predominant elevation of ALT more than the ST. As her main symptoms was proximal muscle weakness, then we arranged the EMG and it showed short duration, low amplitude, motor unit potentials. And the features are in keeping with the inflammatory myopathic disorder. So we arranged a muscle biopsy and it showed significant endomyosial lymphocytic infiltration associated with myofiber necrosis. And there were regenerating fibers with basophilic cytoplasm, vesicular nuclei with prominent nucleoli, and there was no perivascular atrophy. However, as a conclusion, the histopathological features were in keeping with polymyositis. We also arranged the antibody screening, and anti-Jo1 antibodies was normal. Rheumatoid factor ANA was also negative. And we arranged the malignancy screening as well, and CA125 level was also normal. And for the sake of completion, we arranged the end-organ screening, and chest X-ray, pulmonary function tests were normal, and 2D echo was also normal. So, in summary, we came to the diagnosis of polymyositis. So, to begin with, as the first-line therapy, we commenced her on IV methylprednisolone 1 gram daily for 3 days, as she had severe muscle inflammation with severe weakness, and it was followed by oral prednisolone 1 milligram per kg per day dose. There was initial marked clinical response together with the steroid therapy, with CPK dropping from 10,000s to 5,000s. So, as the second step of the management, we wanted to start her on a glucocorticoid sparing agent. But the problem was the marked elevation of ALT more than the AST. So we needed to exclude the other causes of elevated liver enzymes, including autoimmune hepatitis. So we arranged ultrasound scan abdomen, which was normal, and the antibodies, including anti-smooth muscle antibodies and anti-mitochondrial antibodies, both were negative. And hepatitis screening was also negative. So we got the opinion from gastroenterologist team at the Ragam Hospital, and their opinion was it's more likely a non-alcoholic steatohepatitis. So they advised us to avoid methotrexate in the long run as it may cause long-term liver toxicity. And they also advised us to start on azathioprine while monitoring the liver functions. So we started her on initially low dose of azathioprine, which was 25 milligram daily, and we slowly increased the dose to 50 milligram BD over few months. And meanwhile, we arranged a liver biopsy, and it came as normal without any features of autoimmune hepatitis. And during this period, her ALT was also gradually coming down from initial 300 levels to nearly 100 levels. And as the liver function is also coming down, we gradually increased the azathioprine dose up to 150 milligram per day dose. And with time, her CPK also gradually dropped to 1200s. So during the next few months, her ALT was static around the 60s to 80s range. So with managing her with steroids and azathioprine, from one year later, in 2019, she presented again with a disease flare. While she was on azathioprine 150 milligram per day and prednisolone 20 milligram per day. During this presentation, her bilateral proximal muscle power was grade 4 with severe tenderness, and CPK has gone up to 3,700 again. So we thought of commencing her on a second line agent, as this is a refractory polymyositis, and we commenced her on IV rituximab. However, unfortunately, during this infusion, patient developed a generalized body itching with urticarial rash, shortness of breath, and cough. And saturation was dropped to 81%, and we had to immediately stop the infusion, and we managed this event as an anaphylactic reaction to rituximab. So then we had to think of another second line agent. So we, apart from some interval time, we commenced on IV immunoglobulin, initially with pulse therapy of 2 gram per kg dose over 5 days. And with the initial pulse therapy of IV immunoglobulin, there was a good clinical response with CPK dropping from 4,000 to 1,000 levels. And muscle power and tenderness was also improved. So subsequently, we arranged a maintenance dose of IVIG in 4 weeks interval. It was 1 gram per kg dose. And with this maintenance dose also, she had a marked clinical improvement with patient being able to climb up 3 steps without the symptoms. And CPK further dropped to 700s. So we planned the next maintenance dose of IV immunoglobulin in another 4 weeks interval. Unfortunately, during this infusion, patient developed fever, generalized itching, and generalized urticarial rash without any hemodynamic instability or respiratory distress. So we had to stop the infusion immediately, and we managed this event as an allergic reaction to IVIG. So during the next 3 months, in between September to December in 2019, we managed the patient with steroids and azathioprine alone. However, we gradually increased the azathioprine dose to 175 milligram per day. And with time, in latter part of 2019, in December, we found that her liver functions were again rising, which was initially between 80s to 90s level, had gone up to 160s level. So we again took the GI opinion, and their impression was it's more like a azathioprine-induced liver injury. Therefore, we had to stop azathioprine as well, and we commenced on cyclosporine 50 milligram. So during the next 6 months, between January to June 2020, together with acetylcholine and cyclosporine and steroids, patient had moderate proximal muscle weakness and tenderness. And CPK was gradually rising from thousands to 2,500 levels while on both these drugs. Therefore, in June 2020, we again admitted the patient and thought of giving the second cycle of IV methylprednisolone, 1 gram daily for 3 days, and increase the oral prednisolone dose to 0.5 milligram per day dose. Together with this high dose steroids and cyclosporine, patient had only suboptimal response. So, because of the suboptimal response and the refractory myositis, we thought to revise our diagnosis. So then we arranged MRI quadriceps and it was confirmed with polymyositis, and we also arranged a repeat muscle biopsy, and it's also consistent with the inflammatory myositis. Therefore, our diagnosis was confirmed for the second time. And then, since there was only suboptimal response to cyclosporine with high dose steroids, we thought to change the cyclosporine to MMF. And we initiated with dose. However, together with the steroids and MMF also, she has only suboptimal response with mild to moderate muscle tenderness with CPK elevation. Therefore, we thought of giving a third line agent, and the third line agents are currently only available in research data level. So out of the third line agents, IV tocilizumab was the drug available in our hospital during that time. Therefore, we commenced on IV tocilizumab 8 milligram per kg dose on October 2020. And during the first cycle, we arranged 6 doses given in monthly intervals. And with the first cycle, she had a marked clinical improvement in muscle tenderness. And CPK also dropped to 700 from 2000. After the completion of the first cycle of IV tocilizumab, in April 2020, we thought to give as well. And it was commenced in April 2021. And patient's clinical response was static with only mild degree of proximal muscle pain and tenderness. And CPK was persistently static around 700 to 1000s. Unfortunately, we could only give 2 doses of IV tocilizumab during this second cycle, available since July 2021. It's most possibly due to because of the COVID era, and the tocilizumab was widely using for the patients with COVID patients. Therefore, it was not available in our hospital, and thereafter, patient was also lost to follow-up. So, in June 2022, patient reappeared in our clinic with a disease flare with severe proximal muscle tenderness. During this time, patient had been on and off MMF, 1 gram TDS, and prednisolone 10 milligram daily. However, during this presentation, CPK was 2,700s with ALT 60s, maintaining within the 60s range. So, we recommenced her on IV tocilizumab, the rest of the doses which were in the last cycle, together with MMF 1 gram TDS. So, what is the current status of the patient in 2023? She's now in her third cycle of tocilizumab, 8 milligram per kg, together with MMF 1 gram TDS. However, with the third cycle, patient is having only mild clinical response with proximal muscle powers around grade 4 in both upper and lower limbs with mild to moderate muscle tenderness. And patient cannot get up from her sitting position without a major support, and she can't climb the steps, and her activities of daily living are severely affected. The CPK is persistently now fluctuating between 1,500 to 2,500. However, throughout this clinical period, she has no respiratory GI involvement. This is the current status of the patient. Can you play the video? I'm sorry, the video is not playing. Therefore, we'll have to stop here. And we'll give a brief introduction about the polymyositis. Polymyositis is an immune-mediated myopathy characterized by the shared features of proximal skeletal muscle weakness and evidence of muscle inflammation. Female to male predominance is there, with it affecting more in adults than in pediatric population. Insidious or subacute onset symmetrical proximal muscle weakness is the cardinal manifestation of polymyositis. And myalgia and muscle tenderness can occur in 25 to 50% of the cases. Other common symptoms include dysphagia, fatigue, joint inflammation, shortness of breath, and shortness of breath due to respiratory muscle weakness or due to ILD. And laboratory findings include elevated levels of muscle enzymes, including creatinine kinase, lactate dehydrogenase levels, aldolase, AST, and ALT. And autoantibodies can be present, and myositis-specific autoantibodies like anti-Jo1 antibodies can be present in 45 to 80% of the patients. ESR is often normal in polymyositis patients, and if it is elevated, it is mostly due to myositis-associated ILD or a concomitant inflammatory type of arthritis. And testing for myopathy include EMG and muscle biopsy. EMG, there are three main characteristic features. Myopathic changes, including short duration, low amplitude motor unit potentials with early recruitment, and increased insertional activity, such as fibrillation potentials and positive sharp waves, and reduced recruitment pattern. Out of these three major features, our patient had both first two features, including short duration, low amplitude motor unit potentials, and increased insertional activity. And muscle biopsy also includes three major manifestations: inflammatory infiltrates, particularly lymphocytes and macrophages within the muscle tissue, or muscle fiber necrosis or regeneration, and perifascicular atrophy, which is seen only in some cases only. And out of these features, our patient also had inflammatory infiltrates within the muscle tissue as well as muscle fiber necrosis and regeneration, confirming the diagnosis. So to diagnose polymyositis, in the early days, there was a criteria called Bohan and Peter criteria. However, now this is outdated. And currently, in 2017, EOLA ACR classification criteria was made in 2017 to diagnose and classify the inflammatory myopathies. And this classification criteria consists of a scoring system with variable clinical factors, including clinical presentation, degree of muscle weakness, skin manifestations, particularly in dermatomyositis, and laboratory investigations, including anti-Jo1 antibodies and the levels of muscle enzymes and the muscle biopsy features. So a total of aggregated score of more than 7.5 without the muscle biopsy features, or a score of more than 8.7 with the muscle biopsy features is enough to diagnose definitive idiopathic inflammatory type of myositis. So this is considered as the most specific and the most sensitive diagnostic tool in polymyositis. So I will go through quickly about the management of polymyositis as well. BSR guidelines published in 2022 was the latest guideline for polymyositis management. And the recommendations include first-line therapy was high-dose glucocorticoids, and IV methylprednisolone can be considered if the patients have any concerns about gastrointestinal absorption, or if the patient having severe inflammatory type of myositis. And IV prednisolone can be converted to oral prednisolone at a dose of 0.1 to 1 milligram per kg per day dose. And thereafter, we can taper the prednisolone dose according to the clinical response. And after steroids therapy, we have to commence the patient on a steroid sparing agent. And there are several DMARDs, including methotrexate, azathioprine, tacrolimus, cyclosporine, and MMS. and they thought to be used to reduce the muscle inflammation, achieve clinical remission, and to reduce the steroid burden. So BSR guideline says that none of these DMARDs are superior over to the other, and we can use any drug at a given point according to our choice. And second and the third line agents are IV immunoglobulin and the IV rituximab, which can be used in severe or refractory type of muscle inflammation. And BSR guidelines also mention about the cyclophosphamide and the abatacept as the second line agents. Cyclophosphamide is a good option for severe and refractory inflammatory myositis. However, in our case, our patient was very young, and after explaining the adverse effects of cyclophosphamide, our patient never gave the consent for cyclophosphamide therapy. And abatacept is, however, available in the country. And the other third line options are still under experimental levels, and those include TNF inhibitors like infliximab, Janus kinase inhibitors like tofacitinib, IL-6 inhibitors like tocilizumab, and the plasma exchange. There are no sufficient data yet to tell the beneficial effects of these drugs. However, there are ongoing trials, and up to the date, the published case series are promising, and future clinical trials may provide a stronger evidence base. So this is the overview of the basic and escalating treatment modalities in myositis. I will not talk about much about this because the next speakers will talk about it. And thank you very much for kindly listening.
Thank you very much. I thank the colleges for giving us the opportunity to present this interesting case. I'm not going to talk much. It is like going to be a discussion like. So this is, I know, I mean, it is obvious that the management of polymyositis is challenging. So the challenge starts from the diagnosis itself and then go on to the treatment, as you have seen in this case. And it could be either diagnostic or treatment and related things. The diagnostic, like in our case, it is not that difficult because it was kind of a straightforward where they had muscle pains, muscle tenderness, and elevated CPK. But it is not so in most of the cases. It presents in variable ways, and especially the polymyositis is very well known to present in overlap syndromes where you get features of SLE or scleroderma or rheumatoid arthritis or any other autoimmune condition. So you have to be very careful. Like if we treat only one condition, the patient may sort of develop very severe polymyositic related complications if we ignore it. The treatment related are like, obviously it is a life-threatening condition, and I'll speak about few life-threatening situations in a later slide. And especially as with this patient, the steroids and other therapeutic agents and their adverse effects. Like steroids, like I think Udari didn't mention that at one point this patient, she developed severe depression and amounting to with suicidal ideas, and we had to refer the patient to psychiatrist, and she was, for a short period, she was on antidepressants as well. So it could be either disease related or maybe related to the she lifted support for her ADL. So all these things are challenging to the patient, the clinician who manages this patient. This is only one life-threatening condition. You always will have to look into the respiratory function of these patients because like it can get unnoticed. Patient may be sort of comfortably lying on the bed, but you want to take home a message, if you have a patient with polymyositis, take the 1 breath count, neck muscle off, And now the pulse oximeters are omnipresent, so you can check the oxygen saturation. So I'm not going to talk much like this. So we are happy to answer any questions, like if you have any. Later? Okay, thank you.
Thank you, sir. I think we can take questions at the end as well. Right. So it has been increased up to 70 milligrams a day, 175 milligrams a day. And with that, her liver enzymes have gone up. And because of that, a drug-induced liver injury has been diagnosed. So azathioprine has been switched to cyclosporine. And after the switch, she has again started flaring up. She was given IV cards again, switched to MMF, and steroids upped again and started tapering off. Because there was not much of a response to all this, she was started on tocilizumab. Unfortunately, tocilizumab going out of stock and other problems that occurred in 2021, she was lost to follow-up, presented again in 2022 with another flare, restarted on tocilizumab, and MMF and steroids continued, and still she has a residual weakness, CPK is fluctuating, and that is where we are at the moment. So now, Udari also referred to the, in a sense, this is what we have tried to do. We have tried to induce remission, and we have tried to maintain it. In the simplest of terms, we have started with high-dose steroids, added a steroid-sparing agent, and when that was not working, we have gone for second-line treatments, rituximab, IVIG. And when those weren't options anymore, we have tried tocilizumab. And now, Udari also mentioned that She referred to this BSR guideline, which was published in 2022, and all these steps are in keeping with the guidelines. So in clinical practice, when it comes to evidence-based medicine, the clinical practice guideline is the thing that we all want. That is the best level of evidence that we can refer to. So where is the issue? It's with this group of diseases because it is a relatively rare disorder. And if you look at the evidence that has been used to synthesize the guideline, and when it was published and the classification criteria used in these different publications, these have also changed over time. So because of that, we're looking at a fairly heterogeneous group of patients and generalizing the management to that entire to the entire group of idiopathic inflammatory myopathies. And there are many different subtypes that we see clinically with different clinical presentations, as Domingo has said, and also different course of illness, different prognostic factors involved, and they respond differently to treatment. So because of all this, it being rare and all that, there are only a very few clinical trials with very limited number of patients. Around 150 is the maximum number that you will get. And it's a heterogeneous population we are looking at. And the majority are coming from cohort studies and case series. And unlike other diseases, this is a situation where a lot of evidence is coming from pediatrics, from the juvenile dermatomyositis groups, and being extrapolated into adult inflammatory myopathies, particularly even for IV methylprednisolone pulse and things like methotrexate as well. So because of this, if we look at the level of evidence that we are actually referring to, it's moderate at best. It doesn't mean that there's no evidence. There is evidence. That is what we have to go by. But we need to understand what we are actually referring to. So when it's not as concrete as we hope it to be, we have to admit that this is as good as it gets. But then when we apply it, we need to understand the limitations of it and work accordingly. So that's where this patient comes in. Because every patient might not respond the way that we hope the patient would respond to based on the guidelines that we have applied. So that's where the knowledge on pathophysiology and your pharmacology comes into play. And that's where there is room for each individual clinician to select based on their preferences matters. And that's where, of course, experience matters. Sometimes our experienced clinicians would know, based on the patient's presentation, what would work best. So we will take this study and discuss when, what, and why these things have happened, and discuss a few important therapeutic aspects about this patient. Now, starting off with glucocorticoids. This is actually for the non-rheumatologists. Uday also mentioned that it was started with IV methylprednisolone and put on oral prednisolone 1 milligram per kg per day. If you look at the patient, the upper limb power was just 4, lower limbs 3, no dysphagia, no respiratory problems, no ILD. True CPK was 10,000. Now, as Sir said, glucocorticoids are not without side effects. So why have we gone in so hard on this patient? Now, we know that this is what we do with almost all autoimmune conditions. We get joked about all the time thinking that we love steroids. It's because almost all the autoimmune conditions that we're dealing with are due to a loss of tolerance in the body, in the immune system. There are autoantigens that are picked up by antigen-presenting cells that activates autoreactive T cells that ends up with the production of autoantibodies that goes and attacks your own tissues. And that releases more autoantigens that keeps this vicious cycle from going on and on. So with that, the autoimmune response is amplified, and there's further tissue injury that will happen. So at some point, after a certain threshold, we might be too late in what we do. So in these situations, we really do not want to, and we cannot afford to miss the boat. So that's where we need to act fast. And for steroids, there are relatively fewer contraindications. If there's an active infection, yes, we want to go in with it. But early aggressive treatment improves outcomes. And why go for IV instead of oral? Because it improves the bioavailability. One thing is absorption, but it also improves the bioavailability because it bypasses the first pass metabolism. And when we give initial high pulses, it can lower the subsequent doses that we start with oral steroids. So to help us taper off steroids for much quicker, we add on the steroid sparing agents, but this is why we do go in hard and aggressively at the beginning. The second thing we have done is we have started steroid sparing agents. Now, as Dari mentioned, it is to reduce inflammation, it helps tapering off the steroids, and it helps us achieve a steroid-free remission. And as she very correctly mentioned, for idiopathic myositis, there are no head-to-head trials comparing these different agents. And we can't really say what is best because we don't have an evidence base to say what is best for which group of patients. And in practice, we tend to lean towards either methotrexate or azathioprine, and we go for the others much later on because of better tolerability, better side effect profiles, and more experience with using them. And in this patient, why was it azathioprine and not methotrexate? So yes, the ALT and AST were high, and it's a young female. So we know that azathioprine is preferred when it comes to pregnancy and lactation over methotrexate. And if there is an existing liver impairment, it can increase the hepatotoxicity of methotrexate. So because of that, yes, it was not offered initially, and we went ahead with azathioprine. But even with azathioprine, there can be sort of a mild elevation of liver enzymes in about 5% of patients. And it does cause severe hepatotoxicity, but it's less common. And typically, it will occur during the initial period of treatment, within the first few weeks to a couple of months. However, it can be delayed. And if we are to sort of bring in the pharmacological aspect into this patient, now the mechanism of liver injury in azathioprine can be due to its pharmacodynamics, its mechanism of action, or it can even be due to a hypersensitivity reaction, which can be unpredictable, but it's usually associated with other things. You get fever, they get arthralgias, they can get rashes along with a liver impairment. So in a sense, what could happen is that you know that azathioprine is converted to 6-mercapturine, and that is the active metabolite that goes and exerts its pharmacological action, but that is also a toxic metabolite. That is what will cause some of the side effects. And it's metabolized by xanthine oxidase and thiopurine methyltransferase. And sometimes there is a deficiency. There are people with genetic variations who might not have adequate levels of thiopurine methyltransferase, and they are at a higher risk of developing toxicities due to azathioprine. And it can be tested. It is, expensive, and sometimes it's limited in Sri Lanka. It can be tested, and it predicts more of side effects due to side effects on the hematological system, cytotoxicity, more than the gastrointestinal problems. But when you have more and more toxic metabolites that are accumulating, it can go and act on the hepatocytes and and cause a liver injury as well. So in this patient, her liver enzymes went up at a dose of 175 milligrams a day. So from what I understand, the patient's weight is about 55 kilograms. So that is just over 3 milligram per kg, so which is a fairly high dose. And that could have led to the liver enzymes going up about 3 times upper limit of the normal at this point. So now, when it comes to drug-induced liver injury, how do we assess whether it is really due to a drug? We look at the exposure or adjustment in the dose. And it should be a drug that's known to cause drug-induced liver injury. So azathioprine does cause drug-induced liver injury, the dose was increased. And we need to exclude other causes to say that, yes, it was definitely the drug that caused it. So here there is a query of NASH in the background. And when we discontinue the drug, it should lead to an improvement. And usually, when you withdraw the offending agent, in about 3 to 4 weeks, your liver enzymes should resolve based on how bad the injury has been earlier. Or we need to also think of whether multiple causes could have contributed to this. However, in this patient, it could have actually been multiple pathologies that contributed to this, because it had always, even though it came down after taking azathioprine off, it had been around 60 to 80, never really normalizing, from what I understand. And another thing that we also should consider is that the liver biopsy has been done about 2 weeks. We all know that it takes time for things to be arranged here. So it has been done about 2 weeks after starting steroids and azathioprine. So by that time, the liver enzymes have normalized and the histology has essentially been normal. But if you look at the trend in the liver enzymes, they have come down with steroids and azathioprine. And what do steroids usually do to the liver? It causes a steatosis. So if this patient had a steatosis to begin with, we would expect it to remain the same or maybe even slightly worsen. It could be that there might have been some inflammation going. It might not have been autoimmune hepatitis per se, but it could have had some bit of inflammation that was going on that settled with the steroids, now worsening with the drugs and every other thing that we're throwing at her. Right. So I'm not going to talk about the basics of cyclosporine or mycophenolate, but we'll go on and discuss the other things that have happened. So as a second line, now when all this failed, as a second line, we have considered 2 things, rituximab or IVIG. Now, there is evidence for both. There are randomized control trials, albeit with limited numbers. Rituximab, we usually give 2 doses apart, but we've seen that there is usually a more prolonged response to rituximab, and we can wait for 6 months or even a little bit more to repeat if needed. And rituximab, if you compare it with IVIG, is less costly. IVIG, a lot of people do respond to it, but usually because it gets cleared off from the system, you have to give it at least every 4 weekly, and the cost is enormous for that. So yes, we have tried rituximab first. And unfortunately, the patient has developed an anaphylaxis or anaphylactic reaction to rituximab. Now, we know that rituximab is a monoclonal antibody. Because of that, because it's a large molecule, it can act as an allergen by itself, unlike the other small medicines that we use. However, an anaphylaxis is an IgE-mediated type 1 hypersensitivity reaction. So for anaphylaxis to occur, usually there has to be a prior exposure, and these are quite rare. And if you re-administer a medicine, the consequences can even be fatal. And it is important as clinicians that we identify and diagnose anaphylaxis. So that's why I've put this criteria, which is published in 2020 by the World Allergy Organization. So you essentially need only one of the two. If you don't know an exposure and a patient presents with an acute illness with skin or mucosal, or both features involving both, like hives, flushing, swollen lips, plus one of the two, either respiratory involvement with wheeze, cough, stridor, or hypoxia, reduced blood pressure, or with endocrine dysfunction, or severe gastrointestinal system, then yes, you consider it as anaphylaxis. Or there is an exposure to a known agent, an agent known to cause anaphylaxis, or the patient has had an anaphylactic reaction before, and the patient presents with either one of the three: hypertension, bronchospasm, or laryngeal involvement. Again, you need to take it as anaphylaxis and manage. So this patient there is a known exposure, rituximab, it can cause anaphylaxis, developed hypoxia. So, and I was told that there was wheezing along with the skin reaction. So yes, she has developed an anaphylactic reaction. So how do we manage? We have to, number one is, no matter how mild you perceive the symptoms are, you need to consider all of those as severe, because if you don't act, it can be fatal. And there is no place for slowing the infusion down or giving hydrocortisone while the infusion is going on or anything like that. You need to stop the infusion and make sure the airway is secure, that patient's breathing, circulatory support is given, and you give IM adrenaline. Okay. Yes, subsequently you need to give steroids, you can give antihistamines, but IM adrenaline is the mainstay in anaphylaxis. Now, the other thing is that the commonest type of infusion reactions, however, are standard infusion reactions for rituximab. And the mechanism is slightly different. It's due to cytokine release from the lymphocytes as the monoclonal antibodies that you have given goes and binds to the lymphocytes. And these occur typically very early on, within 30 minutes to 2 hours, either during or within a very short period of time of the infusion. And the symptoms, however, can be a little similar, and clinically you might not be able to differentiate whether it's anaphylaxis or whether this is a standard infusion reaction, because they can also develop hives, they can also develop itching, they can develop respiratory compromise, abdominal pain. All these things can happen. The main difference is that with repeated exposures, the likelihood of standard infusion reactions wear off, and they can be mild to severe in severity, but how you would manage it differs. And giving pre-medication, although it does reduce the severity of anaphylactic reactions, they don't really prevent anaphylactic reactions from happening to these infusions that we give. But it reduces the risk of standard infusion reactions, giving antihistamines, paracetamol, and steroid. And if we start the infusion slowly and gradually increase again, the standard infusion reactions are also less. How do we manage? Mild to moderate, we can either slow the infusion or stop the infusion temporarily. We can restart once all the symptoms have gone off. And if needed, we can even repeat the pre-medication. However, if there is any sign of anaphylaxis, and if the patient falls into any of those criteria, if there's any sign of anaphylaxis, they have to be treated as anaphylaxis. We can't miss an anaphylaxis. Right. So the next reaction the patient has got is a reaction to intravenous immunoglobulins. Now, something therapeutically important that we need to understand, that immunoglobulins are pooled from the plasma of thousands and thousands of patients, usually more than 10,000 patients. and they are extracted by an ethanol fractionation, and then different other things are added as excipients to stabilize it. So when we take different products from different manufacturers, the composition will be different. So what you see, an adverse reaction that you see with one product might not happen with another. But adverse reactions, nevertheless, are quite common. If you take patients who have been on immunoglobulins, nearly 20 to 50% of them would have had an adverse reaction to immunoglobulins at some point. And they are more likely at the start of treatment or if the product is changed. And these can again be either immediate reactions or delayed reactions. And how do we manage this? And what increases the risk of this? It has been shown that if a patient has, quite often we use immunoglobulins in a patient who has an ongoing infection and we can't use any other immunosuppressant therapy. And in those patients, because of the underlying inflammation that's already there, when you give immunoglobulins, they can sometimes get reactions to the immunoglobulins. So it's better if we can treat any bacterial infection before we start it. And starting the infusion slow and reducing the infusion rate, again, pre-medication. And if we get a reaction to one, we can try and change the lot number. Subcutaneous immunoglobulins are known to have less side effects. And you know that one of the side effects is venous sinus thrombosis, so thrombotic events. So for that, the patient has to be properly hydrated. Now, we looked at the steroids, we looked at the anaphylaxis reactions, the reactions to IVIG, and then when the patient was not sort of responding, even after methylprednisolone pulse, we have gone ahead with a repeat biopsy to consider whether a diagnosis is right, whether this is actually polymyositis. So one of the things from a therapeutic point of view that we need to consider if there is persistent or worsening weakness is glucocorticoid-induced myopathy. And generally, there's a dose-response relationship. And it's usually unusual if the steroid dose is less than 10 milligram per kg of prednisolone equivalent. Again, you'll see a similar pattern, gradual onset, proximal muscle weakness. However, the difference is they usually don't have myalgias or tenderness, and your muscle enzyme levels will be normal if it's a steroid-induced myopathy, but the weakness will be persisting or worsening. And the EMG can also be normal. Again, will not show inflammation, but there can be atrophy of the type 2 fibers. And usually, if you reduce the dose to an adequate level, they respond, the strength sort of absorb 2 to 3 weeks. So in this case, it's unlikely, it's very, very unlikely. Obviously, the diagnosis is an inflammatory myositis because there was ongoing inflammation, there was myalgia, there was increased CPK. But this is a different thing to consider in patients like this. So we have now tried rituximab, we have tried IVIG, tried different conventional DMARDs, cyclosporine and MMF, and still there is weakness ongoing, CPK is fluctuating. So what are the options now? I'm sorry about the boxes, they were supposed to be text. Now, Udari mentioned that cyclophosphamide was actually offered to the patient. And with experience, we know that this is something that is very, very good. It's a life-saving drug for us in rheumatology. And the problem is that it's converted to active metabolites and that it gets incorporated into the DNA. It's an alkylating agent. And although it works very well, it does have side effects as well. And it can be used as a second line or even a third line if the other agents have failed, especially if there's systemic vasculitis going on. However, along with a number of other side effects that occur due to cyclophosphamide. In this particular patient, this infertility and premature ovarian failure would have been a particular. Understand the patient was counseled, the family was also counseled, but they opted out of it. However, as clinicians, what we need to understand is that the risk is lower, particularly if the patients are younger, and it's very, very rare with a cumulative dose of less than 5 grams. And the doses that we use will rarely come up or exceed 5 grams altogether. And there are certain things that we can do, like offer GnRH agonist to preserve fat. They can certainly try. And the other options that can be offered are like cryopreservation of embryos or oocytes, which can be done even in Sri Lanka. However, this is a good example of where we have looked at the evidence supports it. Expert judgment also calls for it. Clinical substance available, it's less costly, but the patient's preference takes precedence. The patient opts out of it. So all our therapeutic decisions have to take all these things into account. And no matter how much we want to give something, we have to take the patient's preference into consideration. Now, if I am to think of going forward from there, we have tried nearly all the things that we could offer this patient. So where do we go from there? We can either try, sometimes look back and see whether we can try something. Sometimes going forward doesn't necessarily mean just looking forward. We can take a look back and take lessons. So as Udari was saying, yes, we can try JAK inhibitors, try another biologic that's available. Abatacept is not available for us. But on the other hand, can we think of starting with the Trexate at a lower dose in this patient? True, we didn't start it when the ALT was 388, but it has come back to normal. Or maybe can we try re-challenging with IVIG? And we could certainly discuss cyclophosphamide with the patient and the family again, but it'll depend on their preference. And we should also consider at this point the other factors that could be contributing to the persistent weakness and the disability in this patient. There could be an element of steroid-induced myopathy that has set in this patient by now after being on steroids for a long time. There could be an element of disuse atrophy and weakness that's there in this patient. And those things will have to be addressed simultaneously as we think of our pharmacological management, as we think of what more can we offer this patient. So, as I said, whatever we decide on, all this have to be considered. So, if I am to now completely take off my rheumatologist hat and look at this as a simple clinical pharmacologist, this patient, I see something else here. If we look at the cost incurred just in this patient, this is from the standard cost obtained from the MSD, the standard cost for 2022, and also the annual consumption costs are also based on MSD data in 2022. IVIG, which actually is the third drug that costs the most for us as a country, which accounts for 4.7% of our pharmaceutical expenditure, will cost nearly 2.7 million for this patient per year. Tocilizumab, not so bad, about 500,000 if we are to keep this patient on tocilizumab 4 weekly. Rituximab, better, but again, she had an anaphylactic reaction. MMF alone will cost about 82,000 for this patient per year, And if we look at the annual total consumption cost for the country, that accounts for nearly 1% of our annual pharmaceutical consumption. So there is a huge cost involved in treating these patients alone, let alone managing the complications, let alone the added costs of hospitalization, let alone leaving aside the income that she has lost, the disability that's caused to her. So how do we manage these patients when the resources are limited, particularly when the finances are limited? And where does our objectivity set in on deciding what do we offer which patient and at which point? And can we offer the same treatment to a similar patient who comes in another year's time, or maybe who presents to Jaffna or somewhere else? Where's the equity in the healthcare that we offer? And on top of all that, how do we decide where we incorporate newer technologies and newer therapies into our management? That is where health technology assessment comes in. But to do a proper health technology assessment and come to a conclusion, we need to look at so many factors, including the disease, the intervention or the treatment, and the patient groups that we are considering. And yes, we need to be dispassionate in our assessment, but it has to be objective. However, the output at the end of the day will be focusing on the patient, and it's not the illness, because we'll be defining what sort of a patient can be offered what treatment. And we will have to capture data from so many different ends. We need to look at the value of the medicine, not only in terms of the clinical benefit, but in terms of the quality, the quantity of life, that those are the years that the patient will live, or the mortality benefit, as well as the quality of life of the patient. And for this, we need clinical immunological data from our country to do that. We need to look at the cost of how we achieve these outcomes, as well as the income lost in treatment is not properly instituted. So this is from the NHS Scotland, and this is for rituximab for ANCA vasculitis. And they've looked at comparative efficacy, comparative safety, and the economic sort of evidence as well to make this recommendation for this particular product. And why do I say that it focuses on the patient? Because it clearly defines what sort of a patient should, with ANCA vasculitis, should be offered this. That is a person who relapses following cyclophosphamide or who cannot be given cyclophosphamide. So this is where we should ideally heading. And if we can do that, we will have an objective framework for our decision and ensure the entire country. And we'll be involving all different interests so that it will be an inclusive process, and the outcome will be reproducible. However, of course, we do have a lot of challenges and barriers to overcome if we are to get there. We don't have a lot of epidemiological data in Sri Lanka. We have limited expertise. We are not very good collaborators, but we are today. So if we can overcome these, we can get there someday. However, what does this mean to our patient, Ms. M? We can try and define patient groups. We can try and get there, but then we also need to put it into clinical context as well. As I said, inflammatory myositis is a heterogeneous group of diseases. And now this patient has had anti-Jo1 done, which is an anti-synthetase antibody, but there's a whole heap of other myositis-specific and myositis-associated antibodies that can be done, which might help us prognosticate this patient and decide on treatment. Unfortunately, those are not available. So it's difficult for us to define the clinical subtypes which can indicate prognosis. So there'll be a lot of challenges in managing patients like this and in applying whatever guidance that is there to our patients. And on top of all that, we know that, as I said earlier, how one patient responds might be different from how another patient responds because of the nature of the diseases that we're dealing with. So at the end of the day, we might have to actually cycle through different types of treatment modalities to figure out what works best for the other person. And what we can do best is use the evidence that we have, use the experience that each of us have, and collectively as a specialty, take into account the clinical circumstances and constraints that we have in the country, as well as the patient's preference, and make a rational therapeutic decision. So I have discussed the different therapeutic aspects, starting from why do we go in with high-dose steroids, why have we switched from one agent to another. Anaphylaxis is an important point for all clinicians, and identifying it and managing it appropriately. And finally, where we, as a specialty in rheumatology and pharmacology, should be heading. And thank you.
Yes, good afternoon to all of you. Thank you, Madam, for those words of introduction. I'm grateful to both colleges for giving me this opportunity to talk on prescribing in special situations in rheumatology. As we all know, special situations in rheumatology are a much talked about area between specialties. And in this presentation, I hope to concentrate on these special populations. The problems encountered were the lack of evidence and lack of updates on the available evidence. So let's go one by one with what we have. Pregnancy and lactation. So this is based on the article, the immunopines to consider for the use of antirheumatic drugs before pregnancy, during pregnancy and lactation. This is from the Annals of Rheumatic Disease. And the article, this article was published in 2015. So I will concentrate only on level B evidence. And so the overarching principles were family planning should be addressed in each patient in the reproductive age, and adjustments of therapy considered before planned pregnancies. Right? So we know this is far from the situation that we encounter in the clinical practice. And the second overarching principle was the treatment of patients with rheumatic disease before or during pregnancy and lactation should aim to prevent or suppress the disease activity in the mother and the expose of the fetus or the child later on to any sort of harm. Going on to the points to consider, these are all level B evidence again. Of the conventional synthetic disease modifying drugs, those compatible with pregnancy were hydroxychloroquine, chloroquine, sulfasalazine, azathioprine, cyclosporine, tacrolimus, and colchicine. Then the second point was that CSDMARDs, methotrexate, mycophenolate, mofetil, and leflunomide, cyclophosphamide, are teratogenic and should be withdrawn before pregnancy. The third was non-selective COX inhibitors and prednisolone could be used if needed for control of active disease. NSAIDs limited to the first and second trimesters of pregnancy. Still on points to consider, leflunomide, then Janus kinase inhibitors, and selective COX-2 inhibitors with insufficient documentation concerning use in pregnancy were better avoided. And coming to biological DMARDs, continuation of tumor necrosis factor inhibitors, TNFIs, should be considered, especially in the first part of pregnancy. And etanercept, which showed a very low level of transplacental transfer, was recommended for administration right through pregnancy. In lactation, hydroxychloroquine, sulfasalazine, azathioprine, cyclosporine, tacrolimus, colchicine, prednisolone, non-selective COX inhibitors, and celecoxib, provided the child had no contraindications, was deemed safe to be considered to be taken during lactation. Then still on CSDMARDs and TSDMARDs, drugs with no data available or limited data on breastfeeding that applied to methotrexate, mycophenolate mofetil, cyclophosphamide, leflunomide, tofacitinib, cyclooxygenase 2 inhibitors other than celecoxib should be avoided. Saying this, if the patient had to be started on any of these drugs, the lactation should not be discouraged in patients because knowing the pharmacology of these drugs, it is still deemed safe. There was another article on SLE management in pregnancy, which was named Systemic Lupus Erythematosus Management in Pregnancy from the International Journal on Women's Health, published in 2022, which is pretty recent. And they talk about hydroxychloroquine and adverse pregnancy outcomes. They say hydroxychloroquine reduces both risk flares and the risk of preeclampsia. Those are the two dreaded complications of SLE in pregnancy. They're both reduced with the continuous use of hydroxychloroquine during pregnancy. And it also did not show any effects on the neonates by the way of retinal toxicity or long QT syndrome. This was again copied from the journal. Here it talks about preconception and during pregnancy and lactation, what drugs can be used. Hydroxychloroquine, as you may remember, earlier it was told that during pregnancy, the placental barrier is no more, that it should not be used. At one stage, that was the thinking. But now they say all these drugs, hydroxychloroquine, sulfasalazine, azathioprine, cyclosporine, tacrolimus, can be used at all these 3 stages. And steroids, which is prednisolone less than 20 milligrams per day, can be used, again, preconception, during pregnancy, and during lactation. So what are the drugs that are not safe during pregnancy, but safe in lactation? Belimumab, rituximab, and abatacept. Then drugs that are not safe in pregnancy nor lactation are cyclophosphamide, methotrexate, leflunomide, and mycophenolate mofetil. Cyclophosphamide and methotrexate, they asked to stop up to 3 months before, and mycophenolate mofetil to be stopped 6 weeks before. Leflunomide, we know for a long time they talk about the cholestyramine washout because it can be in the system for up to 2 years. Then coming on to NSAIDs, the FDA issues a warning that there can be rare, serious kidney problems in the unborn baby, which can result in oligohydramnios and death in the fetus 20 weeks and beyond. Then around 30 weeks of gestation, NSAIDs can cause premature closure of the ductus arteriosus. But low-dose aspirin can be continued for the whole duration of the pregnancy. It is safe. What about gout in pregnancy? This is from the Journal of Inflammatory Diseases, and the article is Managing Gout in Women, the current perspectives. So allopurinol, colchicine, febuxostat, pegloticase, which is the biological agent, and probenecid have all been categorized under pregnancy risk category C. So that is, there is, in animal studies, fetal harm has been documented. Then the other problem is paucity of RCTs, randomized control trials, in the females, because gout is predominantly a male disease. Then even more, there's a greater burden of cardiovascular and renal morbidity in the female. For these reasons, gout is favored over other pharmacological agents. Febuxostat appears to be more effective in lower dose than allopurinol. Then what about, very briefly, about fertility and the disease-modifying drugs that we use? There is a systematic review on the effect of DMARDs on fertility in rheumatoid arthritis. And contrary to the popular belief, most DMARDs don't seem to have harm on fertility. This is because it results in better control of the disease and actually improves the chances of conceiving. But we can't forget that sulfasalazine can cause reversible male infertility. So it's better stopped 3 months prior to a planned pregnancy. Let's get on to the second group, which is renal disease. So this is an article which is renal comorbidity in patients with rheumatic diseases. It was published in 2011. So as you know, if we talk about the rheumatological diseases and renal diseases, they may originate from the same autoimmune condition. Likewise, rheumatological diseases or their management can result in renal disease, and vice versa, renal disease or its management can result in rheumatological disease. Again, there can be effects when both these conditions are unrelated. So it is a bit complicating. So these are the renal manifestations and the drugs. As you see, NSAIDs can cause acute renal failure, chronic renal failure, proteinuria ranging into nephrotic syndrome. And cyclosporine overdose can cause both acute and chronic renal failure. Arterial hypertension is seen with leflunomide and cyclosporine. Sorry. Now, talking of renal manifestations of rheumatological diseases, most of them would cause a glomerulonephritis. And renal amyloidosis is seen with rheumatoid arthritis and spondyloarthropathies. And giant cell arthritis can cause renal artery stenosis. What about treatment of crystal arthropathies, that is gout and pseudogout, in the presence of chronic kidney disease? Now here, they are not talking of serum creatinine level, they are talking of the GFR. So CKD stage 3 or 4, that is when the GFR is 15 to 59, so 3 would be 59 to 44, and 4 would be 44 to 15. So those patients, and then the other category is where the dialysis patient, where the GFR is less than 15. So thinking of an acute attack of gout, maybe. So most of it should be avoided except for glucocorticoids, which can be used short-term in doses of 20 milligrams per kg or less, 20 milligrams per day or less. Coming on to maintenance therapy, the recommended drug is allopurinol in a reduced dose of up to 100 to 150 milligrams. Febuxostat can be used if the GFR is over 30, but then there are concerns whether it would be effective when the GFR is less than 50. Coming on to unrelated chronic kidney disease and the rheumatic disease patient, arthritis by itself is an independent risk factor for cardiovascular complications in the chronic kidney disease patient. So this deserves rigorous control of the rheumatic condition in the chronic kidney disease patient. Then ONSAs, glucocorticoids, and opioids can be used in the kidney disease patient. Then again, contrary to what most of us think, methotrexate by itself is not nephrogenic. As we go down the CKD stages, because it is excreted via the kidneys, and once we start the drug and the patient has vomiting for some other reason, has a concomitant diuretic maybe, so without actually the patient meeting the physician, the patient can go into renal impairment worsening while on methotrexate, although methotrexate is not a antimalarials, sulfasalazine and azathioprine, dose reductions were proposed when the GFR was less than 50 milliliters per minute. Cyclosporine and leflunomide would increase the blood pressure, and tacrolimus and tocilizumab could cause hypercholesterolemia. For these reasons, all the CKD patients should be monitored for their blood pressure, should have their cholesterol levels looked at, especially being on these drugs should alert you to do it more frequently. What about liver involvement in rheumatic disease? Rheumatoid arthritis can give rise to abnormal liver tests because of disease activity itself, especially alkaline phosphatase. So sometimes we see with treatment of the disease, the LFTs, the liver function tests, and the alkaline phosphatase correct themselves. Likewise, in rheumatoid arthritis or SLE, NSAIDs or methotrexate can cause liver damage and cause elevation of transaminases. Hepatitis viruses can be reactivated with immunosuppression, especially glucocorticoids. So this is another article. This is actually from the the yellow highlight down there. That's from the American College of Rheumatology ACR guidelines, 2008, way back in 2008, says that transaminases about twice the upper limit. If the upper limit is 40, 80 or above, we should not commence or re-challenge with methotrexate, sulfasalazine or leflunomide. Then methotrexate and leflunomide and other biologics are contraindicated in cirrhosis secondary to chronic hepatitis B virus or chronic hepatitis C virus because of risk of reactivation. So this study, which is from the Journal of Hepatology in 2009, says that the highest risk of HBV and HCV reactivation is from using immunosuppression, and steroid sparing agents should be considered. What about NSAIDs and the liver? NSAIDs should be carefully evaluated in patients with cirrhosis regardless of the etiology. Whatever etiology causing cirrhosis, we should be very careful about NSAIDs, especially because it can cause renal injuries secondary to tubular ischemia. And the damage that the NSAIDs cause seems to be dose independent. Getting on to the next population, the elderly patient. This is from Rheumatology, the journal Rheumatology, on management of inflammatory rheumatic conditions in the elderly, published in 2019. Talking about efficacy, there is this concept of EORA patient and the EORA patient, EORA and EORA. Elderly onset rheumatoid arthritis is onset of rheumatoid arthritis at the age of 60 or above, and young onset means when the onset of rheumatoid arthritis is less than 60 years. So what they say is, like in the young onset rheumatoid arthritis patient, the EORA patient should also be started with CSDMARDs and glucocorticoids as initial therapy. TNF inhibitors might be slightly less effective in the over 65-year-old, but improving in clinical response and radiological progression, retardation of radiological progression has been seen with etanercept, infliximab, and adalimumab. Janus kinase inhibitors in patients over 65 and less than 65 at 3 months of evaluation have shown equal efficacy. Still on adverse effects, a Canadian population-based studies showed that increasing age was associated of withdrawing methotrexate or discontinuation of methotrexate in the diagnosed rheumatoid arthritis patient. So there was a higher chance of discontinuation of methotrexate from the rheumatoid arthritis patient when the patient was 65 years and older. In patients treated with leflunomide, adverse effects and survival were equivalent in both the under 65 and the over 65 age groups. Tumor necrosis factor inhibitors was pointed that it would show a higher infection risk. And regarding tuberculosis, reactivation affecting the extrapulmonary sites was seen more commonly. Then, talking about oral glucocorticoids, more than 5 milligrams of prednisolone or its equivalent was associated with a dose-dependent increase in serious infection risk, which would surprisingly be present up to 2 years after discontinuation of therapy. Then an American database on rheumatoid arthritis patients starting on TNF-5s and bio-originated EMAs showed that treatment with methotrexate use did not increase the risk of heart failure. Then oral glucocorticoids showed a dose-dependent increase in heart failure in the elderly patient. And as we already know, glucocorticoids in rheumatoid arthritis would increase the fracture risk and would predispose the patient to sarcopenia. So regarding the elderly, the conclusions would be, it is a permanent challenge with all the other comorbidities treating these patients. And the scarcity of literature is especially seen in this population. And biologic DMARs are still very much an option, considering that actually NSAIDs and glucocorticoids are quite dangerous in this population. However, most elderly patients are still kept deprived of biological treatment, primarily due to the age, which is pretty unfortunate. Regarding the pediatric group, I found this article on Journal Idiopathic Arthritis Treatment Updates, where there are paradigm changes in the management, which includes earlier treatment with biological agents and introduction of biosimilars and Janus kinase inhibitors. So that's it. I think we will be taking up questions now. Thank you for your patient listening. There was one question from the audience. They're asking whether methotrexate is withheld when the liver transaminases are more than twice the upper limit of the sorry. So according to the ACR guidelines in 2008, as I just told you, it should be withheld. Then this is back in 2008, the guidelines, and then I actually spoke to one of the hepatologists and I just asked what they do. They say now that fibroscans are available. They actually, once they refer a patient like this, they would do a fibroscan And if there's an abnormality there, if there's fibrosis, they would stop, otherwise they might continue, they would continue. But there is no evidence anywhere to this. So I think you're quite protected exam-wise if you say twice the upper limit, more than twice the upper limit, you would discontinue. Yes. And they're asking whether you could re-challenge. Yes, of course, you could re-challenge. Then let's get on to our MCQs. Yeah, so the first question is, a 30-year-old woman presents at a period of gestation of 28 weeks with inflammatory arthritis with high disease activity. Which of the following are safe treatment options for her? Celecoxib, cyclosporin, hydroxychloroquine, methotrexate, and tofacitinib. Young people, you're all young, but I'm speaking to the youngest of them. Okay. Anybody wants to answer? Okay, I think I'll go to the answers. Yes, now in pregnancy, FOX2 selective inhibitors were not recommended. Non-selective inhibitors that were recommended in pregnancy. In lactation, you can give celecoxib, but not in pregnancy. Cyclosporin, true, can be continued, can be started and continued if warranted. Hydroxychloroquine, very true. Methotrexate, you can't. It's contraindicated. It's one of the contraindicated DMARDs. And tofacitinib, yes, you can. Any disagreements on that? Okay, so I'll move to the next question. Regarding NSAIDs, can lead to death of the fetus around 20 weeks or later. Aspirin that can be continued for the, bit of mistake. The aspirin can be continued for the duration of pregnancy. Short courses are recommended in CKD stage 3. Can give rise to elevated transaminases. Liver injury is dose dependent. Anybody likes to volunteer? Okay, so I'm going to answer it. Okay, so I told you that the FDA has alerted us that using NSAIDs in the pregnant lady 20 weeks or beyond can cause oligohydramnios in the patient and can cause fetal death. Then with aspirin could be continued throughout pregnancy. Yes, it can. Low-dose aspirin can be continued. Then short courses of steroids, can it be used in CKD stage 3? No, it can't be used. Right? Can give rise to elevated transaminases? Yes, NSAIDs, just like methotrexate, can give rise to elevated transaminases. Liver injury is dose dependent? No, liver injury is said to be dose independent. Now, this is not a question you're going to get at an exam, just for interest's sake, to see whether you were listening to the lecture. Which of the following groups of drugs mostly warrants further research in the elderly? Elderly, 65, let's say. BOD, biological DMARDs, glucocorticoids, NSAIDs, opioid, synthetic DMARDs. The point I wanted to drive here was that glucocorticoids and NSAIDs are causing a lot of damage in the elderly, and if we can afford it, biologics would be actually beneficial in avoiding use of these agents, right? And so, and the problem is there is lack of research regarding biological DMARDs in the elderly. So I would go for, in this single-based response question, I would go for Sorry, got the wrong thing here. It's A. Wrong answer here. It's A. I don't know how it copied. It's biological image is the answer. Okay. Okay. So, Shiranti, to continue.
I know everyone's hungry, the few remaining here. So just a quick things to highlight is one of the areas that we really want you to sort of be thorough with. The advantages of using intramuscular adrenaline in the management of anaphylaxis include rapid onset of action. You could just say true or false. True, yes. Wide therapeutic index. Would it change the therapeutic index? Avoid dense of hepatic first part metabolism, reversal of multiple clinical manifestations, and inhibition of histamine release from mast cells. Okay, so basically, yes, it has a rapid onset of action because it's rapidly absorbed from the blood vessels in the muscles. It doesn't change the therapeutic index because it's still the same for the same medicine. Avoidance of first pass metabolism, it's not really an issue with adrenaline. It does reverse multiple clinical manifestations. Inhibition of histamine release from mast cells. Yes, that's also true for adrenaline in anaphylaxis. And the other important thing of why we give it IM route is if there is no, one thing is, even if there is intravenous access, it should be 1 in 10,000, but 1 in 1,000 preparations that we get can be given intramuscularly, and quite often establishing IV access in anaphylaxis in itself is difficult. So this is about, again, a clinical application of what you all already know. So what are I'm essentially asking, which of these actions are appropriately matched with reducing an adverse effect caused by that medicine? Azathioprine dose adjustment according to TPMT levels. Yes, we do that depending on the level of the enzyme. We sometimes reduce the dose. If they're highly deficient, we don't even start it. Cyclophosphamide administration of Messner following cyclophosphamide infusion. True or false? True, yes, that's to prevent hemorrhagic cystitis that's caused by the metabolite acrolein that is excreted with urine. That IVIG maintain good hydration. I think I mentioned this. It's to reduce the risk of venous thrombosis. Rituximab pre-medication with hydrocortisone. Again, true, mainly for standard infusion reactions. Cyclosporin therapeutic drug monitoring. True or false? Yes, we do that. We monitor the therapeutic levels and then adjust the dose. That's one of the ways that we reduce toxicities due to cyclosporin. Right, so that's it. All are true, essentially. So that's it for the MCQs as well. And, so if there aren't any further questions, I think we can conclude this joint session with the College of Rheumatologists and the Association of Clinical Pharmacology and Therapeutics. And on behalf of both the associations, I'd like to thank all the resource persons and the participants for joining. Thank you.